Hello, we want to welcome everyone to the inaugural Lumea I Know podcast, with today's episode being I Know Vision Correction. I'm your host, Dr. Paul Sanghera, and I'm a cataract and refractive eye surgeon based out of Toronto, Ontario, and co-founder of Lumea. I'm thrilled to have you here with us today. The inspiration for I Know comes from our patients and their most asked questions about vision correction and eye surgery, and we hope that by answering them in a contemporary and accessible format, such as a podcast discussion, we can address topics you often will not see on a clinic website or a web search. Now, let's jump right in, and today I'll be talking with my fellow Lumea co-founder, cataract and refractive surgeon, glaucoma surgeon, and complex anterior segment surgeon, Dr. Basir Khan. Welcome, Dr. Khan. Let's get started. Don't forget to smash that subscribe button so you'll never miss an episode. Please check out our website at www.lumea.io to learn about all the vision correction options that we offer in our 3 Ontario locations. Dr. Khan, welcome.
Thank you, Paul.
You're looking really good today.
I'm trying to keep up with you.
You're also quite a podcast celebrity. You recently just did a podcast last week with a couple of our friends.
Rapid Health, yes. This is I guess this is my sophomore podcast.
Right. Rolling with the big boys, I see.
Yeah, trying.
Yeah. So props and what ups to Andy Galpin, Anders, Chris Perry, and all the crew at Rapid Health Optimization. So let's just dive right in. Me and you we're obviously cataract and refractive surgeons. Let's start talking about cataract surgery. Let's dive in and talk about a topic that's near and dear to our hearts because we sure spend a lot of time doing it. So cataract surgery. So a lot of prospective patients are watching, and let's start right at the beginning. What do you tell patients when they've been diagnosed with a cataract? They come into our office. What's a cataract?
So I think the biggest thing for patients is it's not a disease, and everybody's going to get a cataract. You live long enough. It's just part of getting older. The best way that I describe it to patients is kind of like an onion or a tree. Like every year they're kind of putting on a ring because the lens continues to grow. The thing is, it's in a fixed space. And if you continue to produce material in a fixed space, the only thing that can happen is it's going to get more dense. And as it becomes dense, it's going to be less clear. And it becomes less clear, this lens inside of our eye is going to obstruct our vision. And when that happens, we call that a cataract. And that's how I that's how I describe it. It seems to resonate with people.
Yeah. So when I talk to patients about cataracts, I say, look, you're born, everyone's born with a lens in their eye. The lens is obviously clear in the beginning, and light goes through your cornea and it goes into that lens where it basically gets focused onto your retina. And over time, because of exposure to the sun and obviously because of age, that cataract or that lens gets cloudier with time. So we're both saying the same thing. Once that cataract gets cloudy, it's harder for the patients to see, and the only real option is to remove it.
Some people think, and there's all these I don't know if you've seen them online, like whatever. I can't say it.
Okay.
But the point is, it's a drop that's advertised on the internet as reversing cataracts.
Right.
And patients often ask me about it, and I'm like, listen. If someone's actually invented that, they would be one of the richest people in the world.
Yeah, they'd be putting us out of business too.
Absolutely. So there's no drops that can do things. People are like, well, why can't I just get new glasses? And I tell patients, it's kind of like, it's not the best analogy, but it's a good analogy. It's like, well, if you change your glasses, if your windshield was dirty in your car, it's not going to help you.
Right.
Fundamentally, you got to clean the windshield, which is taking out the cataracts. So to your point, the only thing we can do to address a cataract is to actually do surgery.
Okay, so why don't we dive into that? So we've kind of summarized what a cataract is. It's a cloudy lens in our eye. The only real solution is not a drop. There's nothing you can buy over the counter to make it better. Glasses actually aren't going to help you to see better if you have a cataract. You have to remove it. So I think it'd be pertinent to the people that might be watching just to kind of do just a quick little historical overview in terms of how cataracts were removed way back when was how did we used to get rid of cataracts, and what's been the evolution of technology that's allowed for removal of cataracts today?
So the first cataracts that were done, they actually described 2,000-3,000 years ago. It's called couching. So they take the stick, they'd lick it because apparently that would sterilize the stick, and then they you see these crazy pictures in in encyclopedias and stuff where one guy'd be like holding the guy's head, another person would be shoving this needle into their eye and actually just pushing the lens into the back of their eye. Now, obviously, they're only doing this because the cataracts were like, they couldn't see anything.
Right.
And then earlier in this century, or last century and 20th century, we started figuring out that we actually would better to just take the lens out or the cataract out. And then, interestingly enough, in World War II, when some of these RAF pilots were getting shot down, or there'd be some debris from the windshield in their plane, some of this would get lodged in the eye. And a guy by the name of Sir Harold Ridley noticed that these pieces were actually relatively inert, meaning they didn't react inside the eye. So it's like, hey, why don't I make a lens out of this? So it was actually something that was described in probably the 1950s, but didn't actually widely get adopted until the 1980s. Of actually putting a lens into the eye. So prior to that, people have their cataract out and they'd end up with these really big Coke bottle glasses. But in the 1980s, we started putting lens in and it became widely accepted. Now, I mean, with the technology that we have, and I know we're going to get a bit more into it, it's more, we're able to do so much more than just remove a cataract, but really improve people's vision.
Yeah, so my daughter was actually, we were kind of getting into it a little bit, and I was explaining things to her. And how I would basically summarize that would be, way back when, the only way to get rid of the cataract was to get it out of the pupil axis, and that would just be to punch it into the eye. And that's what couching was, right? And then as we got more advanced in our technology, it's like, punching it into the eye led to a lot of complications. And so we eventually started getting better and better at pulling that cataract out through large incisions. However, once you pull that lens out, there's not a lens to go in. So that's as you were talking about in the 1900s. And the only way that you could then see was you put some very, very thick Coke bottle glasses, I think people still call them. So you had to put a lens outside of the eye to replace the lens that you removed. And then as early as the 80s, we've gotten more prime time and mainstream into now putting lenses into the eye to replace the lens that we pull out. And so that's where we are in our modern day in terms of putting lenses into the eye to replace the cataract. And we'll get into the lens technologies that have evolved.
But I think the other part of that that's really important, Paul, is our outcomes are so good now that we can, like, our threshold to do surgery is a lot less than it used to be.
Yeah.
Before, we used to wait till people's vision was really bad. Now, because cataract surgery is probably the most performed surgery in the world by a factor of like maybe 100 compared to the next, maybe even more.
Right.
Like the volume of surgery.
Because everyone's going to get
everyone's going to need it.
You live long enough, you're going to get a cataract.
Yeah, you live long enough. The two doctors you probably need to see are a family doctor and us, right? I mean, if you're healthy, even you don't need to go see anybody else.
So why do you think that is? Why do you think that our success rates in terms of cataract surgery have skyrocketed, and why do you think that we're so exceptional at producing these very good outcomes with minimal, for the most part, minimal complications? The endophthalmitis or infection rate is less than 1 in 1,000. Why do you think there's been that massive evolution?
I think because of the volume of surgery that we're doing, right? I mean, cataract surgery is a really complex surgery because it's a dynamic environment. Unlike, you're operating on somewhere else in the body, it's relatively stable. It's not moving anywhere. When we're doing cataract surgery, there's fluid. We're using, one of the amazing things is it's a 4-limb procedure. We have to use, our 2 hands are obviously doing stuff, but one foot is controlling the microscope, the other is controlling the machine that we use. And it's a very complex thing, but the thing is we do so much of it, we're really, really good at it. And I think the other thing that's interesting is because everything that we do is through a microscope, it's recordable. And so there's a lot of learning and teaching that goes on through the review of surgery that's been done. And so we've really, really fine-tuned this type of surgery to a point where, again, we can offer it on a minimal threshold. On that point, I would say to you, people are going to say, well, when do I do a cataract, right? And to me, there are 3 reasons to do a cataract. One is because it's medically necessary. And there could be a couple of reasons for that. If sometimes cataracts can cause glaucoma or be a part of that, taking the cataract out can relieve that. Some forms, not all forms of glaucoma. Or if somebody has another eye condition that's preventing the doctor who's taking care of that in the back of the eye to see into the back of the eye. The second reason is because someone's falling below the threshold required for driving. So in Ontario, you need to be able to see at least 20/50 from one eye for a standard license. If you're starting to fall below that threshold and you want to maintain your driver's license, you have to have surgery. Otherwise, unfortunately, we're legally obligated to report people to the Ministry of Transportation. But the third and the most common reason is because someone's simply just not happy with their vision. And so we can actually do that now. Just saying somebody says, you got a cataract, they're not happy. It's like, okay, great, we have something for you.
Yeah. And I think a part of the reason why your patients are so happy with your outcomes is because you're obviously an exceptional surgeon. Probably one of the few surgeons that can do cataract surgery faster than I can. Hate you for it, but that's okay. I want to just kind of zoom out a little bit, just talking about the success rate of cataract surgery. And I'm only going to do that because I want to take it to a question that I think a lot of our patients ask us about. I want to focus in on modern cataract surgery. We've talked about the fact that we have become so good at our outcomes because of the volume, repetition. I think another important reason that, we're doing such good care, all ophthalmologists throughout the world, I think is because of the advent of something called phaco. Before something called phacoemulsification, which is the use of an ultrasound to break up the cataract, what we were doing is we were taking out the lens as a whole. So if you can imagine your eyeball, basically, from one end of the colored part of the eye to the other, about 12 millimeters, right? 1.2 centimeters. And way back even in the 70s and before, how we would get rid of the cataract is we'd have to basically make a semicircular cut around the colored part of your eye. So you're talking about a 6 millimeter large incision, and you'd pull that cataract out, and then you'd suture everything up, right? And so you have this massive...
And people would have to be in hospital for like 2 weeks.
Yes, the
They talked about
sandbags.
sandbags,
Yes.
so you couldn't move your head around.
Yeah.
It was a whole ordeal.
And so we still have patients who say, my grandparents or my grandmother, my grandfather, back in the day when they had their cataract surgery, they were in the hospital for a week. They had sandbags, on the side of their heads. They couldn't move for a week. That still happened way back when. Now, what we've done, especially towards the 80s, 90s, and even now, especially now, is we found a way through, Charles Kellman basically invented this, is something called phacoemulsification, is saying, instead of taking out that lens fully, we're going to break it up inside the eye. And so you're going to break it up into quadrants, almost like 4 slices of pizza, right? And you're going to use then an ultrasound to break it up. What does that mean? What's the benefit of that? The benefit of that is now you can use smaller incisions. So instead of a 6 millimeter incision, our incisions are now about 2 millimeters in size. And so you're working through a very small hole, and you're basically eating up that cataract inside the eye. And so you're pulling out this massive thing through a very small incision. Also, when you're inserting that artificial lens, it's like a taco now. It's folded up into a very rounded taco shape, and you're insert it through that 2 millimeter incision, and then it unfolds inside your eye. I think a big important advancement in terms of allowing us to do these surgeries rapidly and with minimal downstream complications has been the significant reduction in size of those wounds. So I think in terms of quantum leaps for cataract surgery, I think phaco has been huge.
And the corollary to that, or the extension of that, Paul, is the fact, and it's kind of neat when you think about it, and patients often ask, we don't need a suture to close the wound.
Yes.
Because the wounds are small,
Right.
And the way that they're constructed with a bit of a bevel, they self-seal. And the second part of it is, patients often ask, hey, this lens that you put in the eye, are you suturing it in? Do you glue it in? No, it's sort of like you talked about, it sits in this 12 millimeter capsule. All the lenses are designed that the optical part that you look through is 6 millimeters, but they have these little arms that are called haptics that extend inside this bag, and it holds the lens in place, and it kind of gets ziplocked over time.
Yeah.
And so that is really, I mean, sometimes, like Paul, like we do this all the time, and it's very like, sort of, mechanical for us. But I think sometimes we forget about how neat that actually is.
Yeah.
If you think about it, we're putting something permanent in the eye that actually sort of like ziplocks in there and doesn't require sutures. That's actually really cool.
It's pretty insane. Yeah. So, when patients tell me, how does that lens stay in place, right? And so it's pretty cool to say, you have your own lens. It has its own bag or capsule. We're going to make a little hole, a circular hole with our hands to open up the front part of that bag. We're going to use an ultrasound to basically chop up that cataract into little pieces inside that bag or just outside of it. We're going to basically clear that lens of all other, cataract, filaments or anything like that. And then we're going to insert this artificial lens. It's going to be folded like a taco, and it's going to unfold in the bag. And so we're going to reuse the bag or the capsule that held your old lens for your new lens. And you don't have to do anything. There's no suturing. You don't have to do it again. It's pretty astonishing stuff if you actually, for a second, think about it.
And the other thing, again, Paul, that I don't think that I'm just thinking through this, that we sometimes take for granted. We do this under topical anesthesia.
Yeah.
We're literally just putting a drop of anesthetic in the eye, and you can do surgery like that. Yeah, some patients, we like to give them a little bit of IV sedation so they're a bit relaxed, because obviously eye surgery can be very anxiety provoking, and people often say, "Doctor, I'm nervous." And I'm like, who wouldn't be nervous having eye surgery? Like, that's a completely normal human reaction. I'd almost say if you're not a little nervous, it's a little odd.
Right.
But we give IV sedation just to help people relax. But really, and sometimes there are patients that like, I don't want sedation. All we need to do is put a drop of anesthetic in their eye. We can do all of this. Like that's pretty amazing. And so patients are awake, and people often describe it as, I mean, if you're probably born after 1995, you're not going to know what a kaleidoscope is. But those of us who are older than that still remember what kaleidoscopes are. And people often say, "Hey, listen, it's like a kaleidoscope." When I'm having surgery, like looking at the lights. Sometimes for the ones that get IV sedation, I said, listen, it's kind of like being in the 70s. Like, you're a bit high from the drugs. There's a bit of a light show. Just enjoy it.
Right.
So yeah. Anyway, so that's I think we sometimes take that for granted.
We do, yeah.
Funny story though on this. So you talked about the bag.
Yeah.
So we actually do call it the bag.
We do.
It's a technical term.
Yeah.
Wasn't me, but I heard an ophthalmologist one time telling a story about he was operating, and I think a nurse came into the room and he said, "1 second, I have to put the lens in the bag." And the patient he was operating on was an elderly lady, and she said, "Hey, I'm not a bag." He's like, no, that's actually what we call it.
Yeah,
So anyone out there, if you hear us talking about the bag, it's actually a thing inside the eye.
It's a capsule.
It's a capsule. We're not referring to anybody as bag.
That's awesome. Why I wanted to get into that discussion is, because there is a pink elephant in the room, and the pink elephant is now potentially the next iteration of cataract surgery, which we personally, both me and you, and I'm leading you in this direction, find a little contentious, which is laser-assisted or femto cataract surgery. And the elephant in the room, pink elephant in the room for us is we are basically the only surgical center in Ontario, private surgery center in Ontario that does not offer laser-assisted cataract surgery. And this is a question that our counselors and we get literally every day. Why don't you guys offer laser cataract surgery? And here's what we'll often hear in terms of what are the benefits of laser cataract surgery. And we're going to address all these points. We're going to, it's laser, it's more accurate, it's laser, it's faster, it's laser, the outcomes are going to be better, it's laser, it's safer. And so when you have that tsunami of questions from very informed patients, sometimes it's challenging for us to hold the fort and to say, well, we don't offer laser, and patients will often ask why. And I think this is a good discussion point that we should talk about. Why don't we offer, and what's your position on femto or laser-assisted cataract surgery?
So, Paul, you know that I debated a very sort of senior colleague on this last year, and we could spend this entire podcast talking about this. So I'm going to try to be succinct, and you can cut me off if I start to get a little bit too long-winded, which you do routinely. But look, so here, I think there's a really important backstory to this before I get into this, and just for our listeners, you and I were two of the first people to do laser cataract surgery in North America. So we worked with Bausch & Lomb as a company, and their laser platform was called the Victus, and we were the first people in North America to use the Victus platform to do full laser cataract surgery back in, I think, 2014 or 2015. And between the two of us, we did about 2,000 or 3,000 cases. So we're not people who never used it and just said, we don't want to use it. We actually drank the Kool-Aid for all the reasons that you listed in the beginning of this segment. But you and I both know that all the things that you said are not true, which is why we gave up doing laser cataract surgery. It's not more accurate. In fact, and it's not safer. There are large published clinical trials in Europe that were done that with thousands of patients that actually showed that it was less safe. The outcomes were not as good. It's certainly, absolutely, unequivocally, even the guys that are pro-femto will not tell you that it takes less time. It takes more time. And ultimately, at the end of the day, it's especially when somebody's paying for something, there needs to be a value. And I have trouble seeing the value from a safety, from an outcome, from any sort of metric that we would look at to say that this is something a patient should do. And what I say to patients is, look, ultimately, my mom had cataract surgery 4 or 5 years ago, and I didn't want her to have laser cataract surgery. So why would I offer it to any of my patients? I think the challenge with laser, Paul, is, laser, and we'll talk about this when we talk about laser eye surgery to get rid of glasses. I wouldn't do laser eye surgery or laser corrective surgery any other way. But this is a completely different laser that we're doing for cataract. And here's the other thing. You talked about phaco before. Doing the laser for cataracts doesn't actually remove any of those steps. We still have to use the phacoemulsification every single step that we take with quote unquote conventional surgery. We still have to take with laser cataract surgery.
What's laser being used for now in terms of the steps of cataract surgery?
So laser can be used for 4 things. One is the incisions to get inside the eye, but virtually everybody that we know that uses laser cataract stopped using incisions because incisions are terrible. They're actually much better with the surgical steel that we have. It's used to open up that capsule that we talked about, but again, not everybody can have that, and we know that when we do it manually, the capsule is very strong, and what we do with the laser can actually make it weaker.
Can you provide some insight into that?
So think of it as a candy wrapper, right? So like imagine you get a chocolate bar and it doesn't have that little cut that you want. It's really hard to tear open. We look for that little jagged edge, and then then it's easy to open up. The front of the eye is very much like that. And when we open it up manually, it's like that candy wrapper without a sharp edge. But when you do laser, what you're doing is you're firing a lot of tiny little holes, kind of like
tiny little laser holes that are connected, right?
Like a stamp.
Yeah, like they connect.
Yeah. So anyone over the age of 40 still knows what a stamp is. So you have that little tear thing, and so you get these little tags, and there's a bunch of little edges, and so it makes the capsule more prone to tear, and we don't want it to tear. It's not the end of the world, but we really don't want to disrupt the posterior or the capsule in the back. We want to partition the eye into the front and the back, and we like that for a whole bunch of different reasons. And the risk of tearing, particularly going to the back with laser, is much higher, not just in our hands, but in all the studies that have been looking at this in large scale. It also breaks up the lens, but our ultrasound technology is really good. It doesn't really do a whole lot. The last thing it does is it can treat astigmatism. The problem is
Just quickly for our viewers who might be watching, astigmatism, there's different types of astigmatism, but basically when you're talking about something called corneal astigmatism, you're talking about the front of the eye, which instead of being shaped like a perfect half beach ball where all the curves are the same, you might have a long curve and a short curve, almost like a half football.
Right.
And so the laser has been an option to try to rectify that shape to the cornea by working on that more curved axis and basically relaxing it by creating a cut.
And by relaxing it, we're weakening it. And there are some people that have found that we don't want to weaken the eye too much either, because potentially that can lead to other problems. Right. The other problem is, forget that part of it. It's not as reliable. It's not as accurate. I know
we're talking about the corneal relaxing incisions that the laser is causing.
Correct.
Yeah.
We know that with the lenses that we use, they're called toric lenses to treat astigmatism, or even the adjustable lens, which we'll talk about later. Those methodologies or those techniques or technologies are far more accurate in being able to treat astigmatism. And Paul, again, just for reference, I wrote a chapter on this. I've been published on this. I've lectured on this. And even then, even if you are going to treat it, it's only a very small window that this treats. Now, the really contentious part about this, and the dirty little secret, and I know some people aren't going to like that I'm sharing this.
It's going to get spicy now. Spicy.
is here's the thing. So in Ontario, we're actually in our schedule of benefits. This is what OHIP puts out. OHIP does not pay us OHIP pays us to remove a cataract. It doesn't say how we remove a cataract. Whether we take it out the old-fashioned way or we use phaco or we use laser, of course we have to be clinically appropriate. We have to maintain standard of care. But OHIP doesn't pay us any more to do it by laser or to not do it by laser, and the facilities don't get more. And laser cataract surgery is very expensive. Most, it's going to patients are going to get charged an extra $1,000 or $1,200 more, and that's out of pocket because OHIP's not covering it. So the only thing, and they're not allowed, or we're not allowed to bill for something that's otherwise covered by OHIP. And as I said to you, all the components, making incisions, opening the capsule, breaking up the lens, are all part of what's covered by OHIP. The only part that's not covered by OHIP is the part about treating astigmatism. So we can theoretically charge for that, but if somebody doesn't have astigmatism or they have more astigmatism that can be treated with laser and they have to have one of these other technologies, it's actually really it's not okay. And technically somebody is in violation of OHIP guidelines by charging for this, right? And so at the end of the day, to be truthfully honest with you, I really feel, because not everybody is a candidate for laser cataract surgery, and then plus there are higher rates of complications that you have to be able to deal with. Quite frankly, honestly, I don't see a scenario where it's advantageous. And I really see this as more, honestly, as a cash grab of people are playing to patients' sensitivities. Laser must be better because it's laser, right? Because we've been hearing about laser from the laser corrective field and is just assuming that the laser is going to make it better for cataract surgery, but it's not. And this really just becomes a cash grab. I mean, Paul, I've always said, I don't have a problem charging people for our services. We're professionals. We're bringing value to the table, but it has to be something tangible and real that we're delivering. We're not snake oil salesmen. We have to be ethical and honest about what we're charging patients for, and there has to be something real that we're giving patients back, and I don't think that's there with laser cataract surgery.
So I think to summarize, OHIP has a schedule of benefits. It says, it's going to remunerate the physician and the hospital for removal of that cataract by any means.
By any means.
By any means, and that includes whether you're going to do manual cataract surgery or laser cataract surgery. And so that is covered. If we charge for that, that's basically double billing because it's already covered by the schedule of benefits. The only thing that we're allowed to charge for while we use the femto in cataract surgery is astigmatism correction. The quandary that I've had is, well, what happens with those patients where you want to use laser cataract surgery, but they don't have astigmatism? What exactly are you going to be charging them for? And then there's also patients that have a lot of astigmatism, whereby the laser methodology to correct astigmatism is not good enough. And you have to divert over into lenses that correct the astigmatism. So if you're combining the lenses with laser cataract surgery, why are you paying for both to do the astigmatism correction when the lens can simply do it on its own? So the quandary, I completely obviously agree with you, is there for myself. In terms of the value of laser cataract surgery. For me, in my hands, no, it's not safer. No, you're not going to see any better than if I was to do it manually. No, the surgery is not any faster. And let's not forget, you talked about this when you had your debate, the long-term sequelae of doing laser cataract surgery. When you look at that opening, that capsule, there's something that happens to that opening over the long term, like 6 months, 8 months, 10 months down the road. There's an inflammatory component that laser causes, causing something called fibrosis. And so you'll see that opening of that capsule slowly but surely begin to contract in very weird sometimes and very, very significant ways, where you'll see it become a pinhole. And when you see that opening close off, it's almost like a purse string. It's going to close off your entire bag, and it could even shift the lens in your eye, thereby changing what your outcome is.
More than that, Paul, it can even cause what's called a late IOL or lens dislocation.
Right.
Because the lens is held in place by these. I tell patients, think of a trampoline. So trampoline is 3 components. It has the frame, it has the springs, and it has the part that you jump on. Right. So in the analogy here, the frame would be the wall of the eye, the white part of the eye. The part that you jump on is the lens. And those tension lines are called zonules. And those zonules can get stretched and even broken if you get too much of that. And so absolutely. And the final thing I would say on this, Paul, is some of our colleagues, unfortunately, will say, hey, you know what, I'm more comfortable using a laser to do cataract surgery. And with all due respect to my colleagues, I'd say, if you're more comfortable using a laser, then maybe you shouldn't be doing cataract surgery.
There will be instances where you can't use the laser. For instance, if that pupil, you need to have a certain pupil diameter. So when you dilate the pupil to do cataract surgery.
What's a pupil, Paul?
the opening to the eye, right? The colored part of the eye, the opening in the colored part of the eye that allows light into. So it's that small dark hole that's right in the middle of the colored part of your eye.
And the thing with that, Paul, is not everybody dilates well for a whole bunch of different reasons. And those are the patients that are actually more challenging to do.
Yes.
Right? So if you can't, and if you're obligated only to operate on the challenging ones, and you're only comfortable doing the easy ones, then it's a problem. The other thing too, Paul, is we often saw it when we did laser. You do the laser and then you bring them into the OR, and all of a sudden that pupil has gotten a lot smaller. And now you've taken something that should be an easy case and you've made it a harder case. We could just go on and on.
I think we've made our point. Hopefully people that are watching understand why we have a very strong stance about not utilizing femto, and we think that it's obviously for good reasons. It's for the patient's benefit. It's for the surgeon's benefit because we don't need it. Definitely for outcome benefits. And why are we making patients pay for something that they don't need and we don't need?
Absolutely.
So let's move on.
Yes.
We've kind of we've beaten this horse.
Yes.
Yeah. I think we've talked about cataracts, right? We've talked about kind of how we take out the cataracts. We've talked about the things that we like to use and the things that we don't like to use. There's a really important thing that I'd like to get into you with, and that's the lenses.
Which is the most important thing of cataract surgery, because ultimately, that's what a patient leaves the operating room with.
Yes, absolutely. And that is the most important thing in terms of the outcomes, what that patient's going to have. Do you want to talk about just kind of the evolution of lenses in terms of what was the actual first lens or the first foldable lens that was out there that patients were getting 20 years ago, and kind of how it's evolved to where we are today?
So, Paul, just to clarify, we're talking about intraocular lenses, or otherwise sort of known as IOLs.
IOLs, yes. So these are the lenses that after the cataract is removed will then be placed into the eye to give a patient a certain type of vision.
And they're permanent.
Permanent.
They're not contact lenses. They go inside the eye and they stay there.
Correct.
And so the most important thing that I tell patients when we're going through lenses is I need you to understand that except under very exceptional circumstances, whatever you choose is what you're going to have for the rest of your life. We put these lenses in kids and they last a lifetime. Right?
They're going to last longer than you are.
Absolutely.
Yeah.
So you talked about the different type of lenses. The original lenses were not foldable. And so when we had these massive incisions, we would put in these massive lenses. As we started to make incisions smaller, then became the demand to create lenses that could go through this and have them as foldable. And you talked about the taco. So they go in like a soft taco and they open up inside the eye like a taco. And virtually every lens, some are made of acrylic, some are made of silicone, and some variants of those two. But fundamentally, those are the two main materials that we're using today. The original lenses that I used at the beginning of my residency were foldable. They were what we call 3-piece lenses. Then they became 1-piece lenses. And these are technical things that almost not worthwhile getting into. What I will say is I still remember in residency, because lenses don't just come in shapes, they come in powers, right? Because we need to measure the eye to know what power of lens in the eye it goes inside the eye. Right? Just like there's different powers that people wear in their glasses, there's different power of lenses. I remember when we were a resident, somebody needed a 22 diopter lens. We didn't have them there. So what's closest? 24. Fine, let's just throw that in. We would never do that today.
Right.
We're so much more precise, right? So towards the end of my residency, I think just after in 2005-06, we started getting what we call toric lenses. So toric lenses corrected for astigmatism. And that was really a big thing because we had really nothing before then to do that. Then we started getting into what we called multifocal lenses, which were lenses that created vision for both distance and near, because prior to that, we had mono or single vision lenses, which would, in an ideal world, assuming everything else was perfect, would give people good vision in the distance, but they need glasses for reading. Then we got multifocals. The challenge with multifocals is they have rings. And so while they give really good vision in the distance and up close, they give halos around lights at night. And unfortunately, of 100 people that we put a multifocal in, 50% of people probably wouldn't notice the glaring halos. The others do. Of those 50 that do, probably 5 or so would find them really annoying. The rest of them kind of get used to them. The challenge for those people is the 5% of people that found them annoying and we didn't know how to identify them before surgery. There's nothing we could really do to get rid of that. So we moved on. I mean, they're still available, but a newer technology that gives a bit of a range of vision is what we call EDOF, or extended depth of focus lenses, which give a bit of a range of vision. And we've used those quite successfully. And the most recent technology that we're really proud to be part of and be the pioneers of this in Canada as the first center to adopt the technology, and nobody's done more than us up until this point, is the light adjustable lens, which I know we're going to dive deeper into.
Yeah. Yeah. So I think if I was to summarize what you say, we've seen this evolution of lenses that started off way back, I guess, even the 90s they're called monofocals. And the monofocals are still, kind of the bread and butter, things that are done in the hospitals. They're great lenses. The government will cover them. They obviously take care of a cataract, but they don't actually work very well most of the time on prescriptions. So when I say a patient's getting a monofocal, I'll say, look, you're going to see better. You're probably going to wear some glasses, probably going to need something for distance, and you're definitely going to need something for reading. Then along came...
So, and to that point, Paul, just to add to that, so just like OHIP doesn't cover your glasses or an eye exam to get a prescription, OHIP doesn't really care if you're going to need glasses after cataract surgery.
Right.
What OHIP is covering is simply the removal of the cataract so that with or without glasses, your vision's better.
Yeah. OHIP doesn't care about you getting out of glasses. It considers it cosmetic. OHIP doesn't cover anything cosmetic.
Exactly.
So that was a monofocal. And then an iteration to the monofocal became something called an aspheric. You're still wearing glasses, but you're going to get better night vision. And so that became the rage for a while. Then came something called torics. Torics correct that astigmatism, that football shape that patients may have in their eyes by correcting that football inside the eye. And then we got into these presbyopic lenses, so lenses that give you range of vision.
Hold on. What's presbyopia though, Paul?
We'll talk about that.
All right.
You're stealing my thunder. The presbyopic lenses started off with these things called multifocals. And then we moved on to something that's called EDOFs. So how I would differentiate to a patient, if a patient's saying, because I think in the vernacular that's out there, I think patients obviously know more about multifocals because multifocals have been around longer than EDOFs. So you will hear patients come and talk about, doc, I want a multifocal, or doc, what's the difference between an EDOF?
And people have multifocal contacts too, right?
And they do have multifocal. So people know more about a multifocal than they do about an EDOF. So what I say when I try to describe the difference between a multifocal and an EDOF, I'll say, look, a multifocal gives you full range of vision. You're going to get your distance. You're going to get your intermediate computer vision. You're going to get your close-up reading vision. So in terms of what you're going to get as an outcome, you're going to be happy with not wearing glasses. It comes at a downside. And the downside is when you look at the lens under a microscope, you're going to see rings in the lenses. And those rings are what engineers have created to give the range of vision by breaking up the light. But you're going to see them, those rings have manifestations at nighttime when your pupil expands because it's dark. And so patients will see glare and halo at night. And that's been the big kind of bone I have to pick with multifocals. It's the bane of our existence when we're ophthalmologists, because patients will come with a successful surgery. They'll have that full range of vision and they'll complain incessantly.
And they'll see 20/20.
They'll see 20/20.
Distance
They'll read
and close.
They'll see perfectly.
And they'll be like, yeah, doctor, I can see that, but I'm not happy with
I'm
my
not
vision.
happy,
Yeah.
even though I can see perfectly well and I see everything I need to see during the day. It's the nighttime that's bothering me. Here's our problem. We're handcuffed. We can't do anything about glare and halos. You can't have them wear glasses. You can't put drops in. There's no solution except taking out the lens.
Which we can do,
Yes.
but it's not ideal.
It's not ideal.
It's not ideal.
Yeah. So then along comes these things called EDOFs. EDOFs, if you look at them under a microscope, they're like, for a very kind of layman's point of view, there's less going on there, right? There's no rings. There's kind of these little aberrations or these little bumps that you might see on the surface of the lens. But if you compare a multifocal under a microscope versus an EDOF under a microscope, it's going to look smoother with an EDOF. So there's less stuff going on the surface of the lens.
Sometimes you can't even see it.
Sometimes you can't even see it,
they look like monofocal lenses to us.
So what's the manifestation of that? Patients will get their distance vision. They're going to get their intermediate vision. They won't get as much near. So,
if we correct both eyes for distance.
Exactly. So how do we deal with that? We'll do a little bit of an offset. So we'll make the dominant eye more for distance. We'll make the non-dominant eye a little bit more for reading to kind of max out that range. So, but what's the benefit? So now you might not, even with that, get as much close-up vision as a multifocal. So you might not be able to hold something to your nose or read a pill bottle. But what do you get? You get functional vision. You get your phone, you get your computer, you get your distance vision. And because there's not much going on the surface of the lens, your night vision issues are greatly reduced. So when a patient comes to me and says, hey, I have an EDOF in my eye, I'm happy with my lack of night vision issues, I can see pretty well for close up, but the fine print or the pill bottle, I can't really see. I have an answer for you. When you really need to read a pill bottle, throw on a cheater. I have a solution for that. I do not have a solution for night glare and night halos when it comes to a multifocal. So the number of patients that have been unhappy despite successful surgery with EDOFs have been much less, at least in my experience. I'm sure you agree.
Yeah, and there's one other point to this, Paul, too, which is, and you reference this, with the multifocal lenses, we're breaking up light. And that's fine for somebody who has a completely normal eye. But if you've got a little bit of diabetic changes in the back of the eye, if you've got a little bit of glaucoma or macular degeneration or any other issues, it's not a good thing. Whereas the EDOFs, you're not actually losing light. And I would never consider putting a multifocal in an eye that had any of those problems, but I will routinely, as a glaucoma surgeon, in patients that are otherwise appropriate, consider putting in an EDOF lens if a patient wants to do that, because you're not harming the contrast sensitivity. Because the other thing that patients complain about, Paul, as you know, with the multifocal lens, is not just the glare and halos. A lot of them will talk about waxy vision, because they're breaking up that light. They're getting, imagine instead of 100 watts coming in, you're getting 50 watts for near and 50 watts for distance. And it's overall less clear. So that's the other issue with multifocals.
So I think what you're talking basically about are basically inclusion and exclusion criteria. We have to be much more rigid when we're choosing a multifocal for a patient in terms of what's the inclusion and exclusion criteria. Basically, they have to have a perfect eye. You have to look at their cornea. Their cornea has to be pristine with no issues, such as something called epithelial basement membrane dystrophy or any type of swelling in the cornea or scars in the cornea. You have to look into the back of the eye, and you have to look at the retina if there's something called an epiretinal membrane. Again, these are clinical terms. So basically,
anything that's not normal.
Anything that's not normal, we shy away from putting multifocals in their eyes. That gets loosened up when you're talking about an EDOF. So if somebody had a minor scar on their cornea, which can happen, there might be a foreign body, somebody gets a metal filing in the eye from years ago, they have a small scar or something like that. Somebody has a mild epiretinal membrane from age. You probably don't want to be putting multifocals into a lot of those eyes.
No.
But those patients are still motivated. They want to get out of glasses. And it's a shame to take that away. Well, now with the EDOFs, we can loosen those inclusion criteria or exclusion criteria. And those patients, because there's less going on with the lens and less aberrations caused by those rings or the lack of rings, we can now access a more of a demographic of patients that have close to perfect eyes, but still where they're allowed to get what they want.
So let's talk about our EDOF on steroids.
The EDOF on steroids, yeah, the EDOF on steroids. That's the light adjustable lens. That's been the. I don't know about you, but you're 20 years in. I'm right behind you. We've seen all these changes, right? We're the Phaco generation, right? We learned on Phaco. We saw the 3-piece and all these lenses come. We've seen these iterative changes. The multifocal was pretty cool, but it wasn't perfect, right? Because you were dealing with a lot of these night vision issues. The light adjustable lens that's been available in the last 2 years, for me, in my almost 20 years of practice, has been the most show-stopping game changer of lens technology that I've ever experienced.
I would take it further, Paul. I would say it's been the most important advancement in cataract surgery, period, for as long as I've been in practice.
Yes.
Like, not just lenses. I'm saying all things, right? Because Phaco was already established when we came into practice. I mean, Phaco is important.
Right.
And I would say it's more important even than adjustable lenses, but that was already around. So in the time that we've been in practice, to me, this is the most substantive technology that we've now had at our disposal. Look, when patients come in, like I talked about this before, we have to pick a power for a patient's eye. And we put people through a battery of tests, like a lot of testing, because we want to measure the eye, right? We can't take a patient to the operating room, like you go to optometrist, say which is better, 1 or 2, 1 or 2, 1 or 2. We can't do that. We have to just pick a lens and
we basically have to predict
yes,
the optimal outcome based on a pre-operative measurement of the eye. So we have to measure the eye before surgery. We have to use various calculations based on those measurements to predict that zero prescription that we're trying to get.
And we're pretty good at it.
Really good at it.
We're
most
really
of the
good
time.
at it.
Most of the time.
But the thing is at the end of the day, as I tell patients, your eye wasn't made by Honda. Like, I don't have blueprints.
Yes.
And because of the way the eye heals, it's a biological structure. We cannot fully predict how something's going to heal. So even like if something, like we deal with microns, right? A micron is 1,000th of a millimeter. And even if the lens moves 10, 15 microns, that's the difference between somebody maybe seeing 20/15 and seeing 20/25, right?
Absolutely.
There's a difference. So the nice thing with the adjustable lens is our ability to make this bespoke. So the analogy that I would make is like, what are you, Paul, 42?
42.
42. Hey, there you go. See, I could have, this is my life as another job.
You're being generous.
Thank you. So let's say let's say you were 41, right? So 42 is a little too big, 40 is a little too small. You want to show off your V figure there. The 42 is you just wear it and it's just going to be a little
Off the shelf.
It's off the shelf.
Yeah.
That's what a standard lens is.
Yeah, off the rack.
It's off the rack. It's close enough.
Yeah.
Right? The adjustable lenses, you bring that 42 in. A month later, you've sort of worn it in, you've worked it in, it's stretched a little bit here or there. Now we're going to taper that in. So maybe it's 41 3/4.
Yeah.
But it fits you like a glove.
Right.
Right? And that's what the adjustable lens allows us to do that we simply had no other option.
Right. So basically for the people watching who are not familiar with a light adjustable lens, unlike all the other lenses that we've discussed, the light adjustable lens is the same at the outset. You do the cataract surgery, you insert the artificial lens into the eye, you give it about a month to heal. It heals very well. We usually target patients for distance and they see pretty darn good, just like most lenses for distance. What's different about the light adjustable lens versus all the other lenses is there's something called silicone monomers that basically are light sensitive. So what happens after a month, we take the patient into something called our light delivery device room. So there's something called an LDD that we can that shines a wavelength of ultraviolet light onto the lens. And this is not in an operating room. This is just in a clinic setting. And that ultraviolet light will change the shape of the lens. So we can change the shape of the lens inside the eye after the surgery is done, and we can do it for up to 3 times. We can change something called the sphere.
And this is non-surgical.
Non-surgical. We can change something called the sphere, which is that first number in a prescription, up to 2 diopters, so plus or minus number 2. We can even change the astigmatism, which is the second number in your prescription, plus or minus 2. So the analogy I like to do is, let's say 0 prescription, perfect outcome is the hole. Right? You're on a path, you're on a driving range. You got to hit a hole in one. Now, me and you like to think we're Tiger Woods, which we're
I didn't know you played golf.
I don't. But we're getting close to the hole. I'd like to think we're pretty good at what we do.
Yeah.
And we're getting really close to the hole. Sometimes we'll even hit a hole in one.
Yeah.
And we'll get 0.
Although how many times have you seen that in your career?
Not very many. There's not very many.
Outside of the LAL.
There's not many ophthalmologists that can say that with consistency, they hit 0 prescription.
Even without Paul, I think in my career, I've seen like 0, like no prescription of sphere and still after surgery, maybe once or twice.
Yeah.
It's a blue moon.
Yeah. And that's not to say that, we're really far off. Our outcomes might be, minus 0.25 plus 0.5, right?
Yeah.
It's like we're close.
We're very close.
But we're not hitting that hole in one every time. Now the light adjustable lens, because we can alter the shape of the lens after the surgery, that's like having a putter. That's like saying, okay, all I really have to do is get on the green. And now I have 3 putt attempts to get it to 0. And I think that's been the game-changing aspect of it, is unlike all the other lenses, which we have to predict an outcome. And let's not forget, we're measuring an eye that hasn't had surgery. Now I'm doing a surgery. I'm cutting that eye. So now I have to take into account, predict not only what the lens power is, but predict what my surgery is doing to the eye. So these are all these variables that account for us not hitting that perfect 0, even though we're attempting to hit that target. And now all I have to do is get close to the green and let the light adjustments do the rest.
And we're getting to a stage where the people who earlier on, maybe in the 2000s, had laser eye surgery are now needing cataract surgery. And as good as our algorithms are, and they're very good, they're less accurate for patients who have had previous laser vision correction.
Yes.
And so our ability to have that ability to tweak after surgery to get those outcomes is great. Because Paul, what's the difference? Like, what are you happy with? Like, you're pretty happy with 20/20 with virtually any other lenses.
Pretty
right?
close, yeah.
But what do we see with the adjustable lens?
So, we did for that same meeting that you had your debate on, I also talked about the light adjustable lens. It was a conference, a major conference for cataract surgery. So we did a deep dive on Lumea's outcomes. The last 200 patients who had normal eyes, and we looked at what their distance vision correction was. Out of the 200 patients, not a single one was less than 20/20. And I would say half of them were better than 20/20 at distance. So can you imagine having a lens technology where if you took 200 eyes and none of them were less than 20/20, that is
They
exceptional.
were better than 20/20.
Yes, exceptional outcomes. And the reading vision with a light adjustable lens, which we haven't really gotten into, but you can adjust for reading for this lens, and it's not a multifocal. It's analogous to an EDOF. So we're baking in reading vision. They're getting their distance vision. So the average outcome of 200 eyes from our analysis was average distance vision 20/20. Average reading, J2, which is basically fine print. And
That's like 2025.
yeah,
per reading.
absolutely insane.
And that's probably the size of something, maybe even smaller than a medicine bottle.
Yes. I mean, there's no technology like it on earth. Now, I would say, what are the drawbacks? So what do you think why would a patient not wish to have an LAL or might not be a candidate for an LAL?
The biggest reasons we wouldn't do clinically, why we can't do a light adjustable lens, is if their astigmatism is more than 2.25 diopters, which quite frankly is actually probably less than 5% of the population. And number two is if they don't dilate, because if they don't dilate very well, because the adjustments require this light being able to hit the lens. And so if somebody doesn't dilate more than 6 millimeters, then they're just not clinically a candidate. The only other reason that are non-clinical for patients would just be they just don't have the ability to come in, because it is a bit of work, right? We do the cataract. So most patients, for any other cataract surgery, we do the cataracts. And we see them within the first 24 hours typically, or at least call them. We check on them, and then we see them within the first week. And then we're pretty much done. This lens, we do that, but then we see them at a month, and we start to see them weekly for probably anywhere from 3 to 5 times, depending on how many adjustments, and there's a lock-in period too, right? So there's all these sort of treatments that we do. So there's more work for patients. So they have to commit to that. They have to have the time for that. Now, the good news is that they're not time limited. We give them some special glasses so they don't inadvertently get exposure. Really, the only thing that they shouldn't be doing during this time is go to a tanning bed, which is probably bad for you anyways.
Right.
But other than that, they can pretty much live their life. And if it has to be a few weeks here or there, no big deal. We've had international patients come to us, and we've been able to squeeze their schedule so it optimizes them. So really that's it. And quite frankly, there's a cost, and it's not cheap. But the flip side is there is literally nothing else that we have that even comes close to the precision and the outcomes. I mean, Paul, I know what you're going to say, but I'm going to ask the question. If you had to have cataract surgery today, right? It's not even a discussion.
My mom's getting an LAL.
Yeah, I wouldn't even consider. I mean, it's the first time in my career where I can look somebody in the face and say, because when people are I don't tell people this off the bat, but a patient will ask, "Well, doc, what would you do?" And I'm like, without hesitation, I would not consider putting anything else in my eye.
We and to that point, in our practice, we have a practicing ophthalmologist who has the LAL.
Yeah.
We've had tons of optometrists that we've done cataract surgery on who have LAL.
And even outside of our practice, we know that just about any other ophthalmologist that cataract surgery in the last couple of years has had an adjustable lens.
Yeah.
Right?
It's been.
Yeah. By the way, you won't toot your horn on this, so I'm going to. Which is, we hear some of our U.S. colleagues talk about the light adjustable lens, and they'll be like, "Yeah, it's okay. I don't use it, or only for special circumstances." Paul, because you lead the Lumea team. You and Dr. Salwan, who's the optometrist who works with us to do the adjustments, you guys really spent a lot of extra time, even beyond. I mean, the company that makes the LAL has been very good about supporting us, but you and Dr. Salwan really, iterated the follow-up and the algorithm of adjustments really, really at a high level. And I think it's because of that commitment. You know, it wasn't just plug and play for us. You and Dr. Sullivan really studied this, you understood it, and you've really optimized the adjustment algorithm. And I think, you know, I don't like to give you credit too often, but no, you know, our outcomes are a direct result of the fidelity and the interest and the effort that you and Dr. Sullivan have put into finding the optimal adjustments.
Appreciate it. I know that was hard for you. No, I enjoyed it because, you know, and this is going to segue into what we're talking about next. You know, my history also as a refractive surgeon doing laser vision correction is basically the intersection of cataract surgery and refractive surgery, because now you're dealing with prescriptions, right?
Yeah.
The cataract surgery is done, and now you have these very interesting, unique, minor prescriptions that from the laser vision correction space I had experience in dealing with, and I think it served as a nice kind of union of the two, laser vision correction or refractive surgery and cataract surgery. So it was kind of fun, and Dr. Salwan has been amazing too, and you know it's been great working with him to optimize these things. It's not plug and play. There is definitely an art to doing the adjustments, and I think, you know, we have a great team, and the outcomes speak for themselves.
Yeah, and just on that again, just we've had more experience with this than virtually anybody else in Canada.
Yeah, no, we were first to jump on, and we just continue to plow through because it's just the word of mouth is incredible. Yeah. Like it's you know, patients are doing the marketing for us. Though the number of friends and family that they send it's insane. Okay, so we're gonna segue into another section of the podcast, and we're gonna be talking about laser vision correction. We originally had mentioned a pink elephant in the room. There was one. It was femto or laser cataract surgery. There actually is a second elephant in the room, and that's Basir. Why would a laser refractive surgeon like yourself still be wearing glasses?
Yeah, I often do get that question, although I try to preempt it when on days, because you walk in, I'm like, hey, I'm going to do your laser eye surgery, and they're staring at me. They're
At
like,
your glasses.
They're staring at my glasses. I'm like, listen, if I could, I would have like laser eye surgery tomorrow. Just unfortunately, not everybody's a candidate, and I'm just not a candidate. I think it's worth noting that you've had laser eye surgery.
Oh yeah,
yeah. So
I mean,
10 years ago, 12 years
longer.
ago?
So I mean, I forget when I started doing laser vision correction. I think it was probably 14 years ago, and I had glasses. I was like a -4, -5. I'd wear contacts when I was doing surgeries because I didn't want to answer that question either. That lasted for a year. The outcomes were so impressive. The patients were so happy. It didn't make sense for me to be seeing all these patients who were so happy having something that I wanted, that a year into it, I decided to get my laser eye surgery done too. It's been years since I had it done. I haven't looked back. I thought I would. You have this nostalgia for glasses because you've been wearing them for so long. I thought, oh, I'm going to miss my glasses. Not a chance. From day one, it was over. The only thing you'd catch me doing would maybe pretend like I had my glasses on when I didn't. But that left after a couple of months. It's been a remarkable thing. It's probably one of the best things I've ever done, which is getting.
And Paul, you're not the only one. We have a lot of colleagues, like a lot of ophthalmologists. I mean, sometimes some of our friends will say, hey, I never seen an eye doctor who did laser eye surgery. There's actually a lot of us.
Yes.
Like there's a good percentage of docs we know that have had some really top-notch surgeons too, that have had it done.
Yeah.
So yeah, it's, I mean, I will say, look, I mean, at the end of the day, wearing glasses is obviously safe. You can't really, nothing bad can happen. But you know, what I tell patients is laser eye surgery is way safer than wearing contacts every day.
Yes.
You and I have seen no shortage.
So yeah, can you
problems.
Explain that?
Yeah. So like when you're wearing a contact lens, right? So first of all, a lot of people overwear them. So what does that mean? Like your eye doesn't have blood vessels on it, because if it did, you wouldn't be able to see. Like the clear part of our eye, or cornea, that clear dome that sits on the front, doesn't have blood vessels. If it did, you wouldn't be able to see through them. So, but it's still living tissue. How does it get its oxygen? How does it get its nourishment? It gets that from being exposed to the air. When you're putting a contact lens on your eye, there's a certain amount of lack of penetration of those nutrients and the oxygen that's getting there. And if you overwear your contacts, that can cause damage to the surface of your eye. We certainly see that. And then, of course, there's a concern about infections, right? Even if you when you put in a contact lens, you get what you call like little tiny micro abrasions or micro scratches on the surface of the eye
From the movement of the
the lens moving up and down. And as that breaks down that surface, it can allow bacteria to go. And even with people with dailies, I mean, obviously dailies are better than like lenses that people put out in their cases and put them back on. And the worst thing is, the absolute worst, and hopefully this is a public service announcement, is don't wear your contacts going into freshwater lakes.
Yeah.
Right? Because you can get an infection called acanthamoeba, and that's like
Brutal.
That's like eye threatening. Like you can lose your vision from those because they're not easily treatable. So the short of it is that, if you're if you're going to wear contacts once in a while and you're otherwise wearing glasses, fine. Like, play like you did, like just throw on a pair of contacts when you're playing sports or whatever, fine. But if you're one of those people that's wearing contacts 3, 4, 5 times a week for 8 hours a day, you're far better off having laser eye surgery.
Yeah. Yeah. So I to summarize, I would probably say from a safety assessment point of view or a cumulative safety risk, somebody who's wearing contacts for years on end, probably cumulatively speaking has a higher risk of infection than what you get from laser vision correction. And from a cost perspective, obviously, all those years that you're buying glasses and contacts, you add them up, you probably end up paying more than you are going to pay for laser vision correction.
Paul, how often have you seen an infection after laser eye surgery?
Yeah, you rarely see it. And I think that's what I'd love to jump into, which is kind of the safety profile of laser vision correction, how it's kind of evolved. The earliest days of laser vision correction involve something called PRK, which is kind of our oldest technique. So, as you were talking about that cornea, the cornea has several layers to it. The outermost layer that the air touches is called the epithelium. PRK was the oldest laser technology or technique. You would basically scratch the cornea. You'd scratch that epithelial layer or that skin layer off. You'd laser on top to remold your cornea, and then the epithelium or the skin would regrow. It worked. It still works great today. But man, that's painful.
It is painful. And it takes about 6 weeks
Yes.
to get your vision. Paul, I think there's an important part here is that, when light hits the eye, it has to get focused on the retina, which is in the back of the eye. And there's 2 things in the eye that are responsible for focusing light. The lens we talked about when we talked about cataract surgery.
Yep.
And in a young person, it's adjustable, and that's what allows people to see up close and far. And it's responsible for about 1/3 of the focusing. The cornea, which is that clear dome, is responsible for about 2/3 of the focusing. And what we're doing when we do laser eye surgery is we're changing the shape of the cornea by removing tissue, because we can't add tissue to the cornea. We're removing tissue strategically to change the shape of the lens, and that changes the power of the eye, and that gets people out of glasses.
Yeah, and people might be saying, hey, wait a second, you guys talked about how you didn't like laser cataract surgery. Laser cataract surgery to cut certain things can work in various tissues. Doesn't work very well in some of the tissues for cataract surgery. Laser to take away a corneal tissue or to cut a corneal tissue works really well.
No, it's extremely precise. Like we talked about microns, 1,000th of a millimeter. We can remove 0.25 or 1/4 of a micron at a time. It is super, super precise. One of the things I like about doing laser eye surgery is it's a different group than our cataract patients. They're young patients, but it's such a precise surgery that there's just nothing really else that comes close to it. And as safe as cataract surgery is, like LASIK is even, or laser eye surgery is probably even a magnitude order safer than that. It's super safe.
We'll talk about it, but if we're talking about, we're going to talk about the different technologies. PRK we just talked about. We'll talk about LASIK. We're going to talk about something called SMILE. But if you're talking about LASIK and SMILE, oftentimes patients might have some concerns about outcomes. What's the worst that can happen? And I will tell patients, when it comes to Smile or LASIK, the worst thing that's going to happen to you, let's say there is an inopportune or there's an issue. The absolute worst thing that's going to happen to you is you're going to walk out the door with the exact same prescription that you walked in the door with. That's it. The worst thing that's going to happen is we're not doing the laser.
No, we stop.
We stop. And so I think when patients hear that in terms of safety and you mean I'm not going to lose vision, I think they get very reassured. Laser eye correction has become very safe.
I think there is one thing about. I think people do get a bit of a dry eye, right? Like that's
a complication.
I wouldn't call it a complication.
That's a side effect of any laser.
100%.
Anytime you're reshaping a cornea, so you're removing tissue, you're inevitably hitting nerves in the cornea, right? You have to. And anytime you remove or you damage nerves temporarily, because they will grow back, you're going to cause dry eyes. So Smile, LASIK, PRK, anything that alters the corneal tissue is going to inevitably lead to some dry eyes.
So Paul, you explained PRK. Why don't you explain LASIK?
Yeah. So, PRK was great because as the only technology, because yes, patients were getting great, highly accurate outcomes. You're creating usually about a 6 millimeter, which is a large corneal abrasion or scratch on the cornea. It hurts. Imagine a large scratch. So you get an outcome, but you're waiting 4 or 5 days to heal your epithelium. So you're at home. Your eyes are closed, you're in the dark, it's not fun. And then it takes 6 weeks to get your final outcome with PRK, but it worked. And back in the day, that was all we had. Then along came somebody that says, hey, is there a way to avoid that scratch on the cornea? Can we somehow make it easier? So what they did is, there was an adventation called a microkeratome or a keratome. What this would do, it would basically, almost like a book, you would open up a book or you create a slice of the cornea and then you create a flap.
So it's a super fine blade.
A super fine blade that basically attached to the eye to create usually about 120 micron flap. And now what you'd lift up the flap, you would do laser with the excimer laser basically to remold the cornea.
The same laser we use for PRK.
Just like you did, you're still remolding the cornea, but now where that scratch is, you're putting the flap back down. And so instead of a massive flap, all you're doing is you're healing that flap along the sides. So in terms of benefit, instead of 5 days of pain, you have 12 to 24 hours. And in terms of waiting, the difference between waiting 6 weeks for your outcome, you're waiting 2 or 3 days. So in terms of effectiveness, just as good. They're both the same. But in terms of safety profile, in terms of getting an outcome faster, it was amazing. What are the downsides of LASIK?
Yeah.
You have a flap, right? And we've become very good at replacing that flap where it's supposed to be. But inevitably, the one thing that we still worry about when we do when we do LASIK is that flap might shift a little bit in that early postoperative period. That can cause wrinkling in the flap. That's why we see our patients, post-op day 1 to assess for flaps. And if we have to, sometimes we have to reposition that flap back in place.
But it's not just short-term, Paul, though, right?
It's not just short-term. It's long-term as well. Because you never fully get the same tensile strength, you don't fully heal a flap, right? It's a cut.
The eye's so specialized.
It is so specialized. If you get an injury, let's say, and we've seen this, let's say there's a branch that hits that flap perfectly. It could be years out.
Basketball, we've seen it.
Basketball.
Someone's dog.
Yes, you can shift that flap even years later. It has to be one of those freak incidents that hits you perfectly right at that flap edge to move it. But yes, that is a consideration, is that flap shift can happen years later after trauma.
So that's why we don't like doing LASIK in somebody, particularly who's maybe, like if it's a professional basketball player came to us, we wouldn't want to do LASIK. If an MMA fighter or somebody who's grappling a lot, we wouldn't want to do LASIK on them because of the risk of moving that flap, even long term, like 10, 15, 20 years later.
And I would say, prior to several years ago, prior to the advent of something called Smile, LASIK was all you had.
Yeah.
So
Well, you did PRK.
where you did
on them.
PRK.
Yeah.
You did PRK. So some of those boxers
Yeah.
or whatnot, sometimes you'd have to
Yeah.
revert to PRK
Yeah.
Instead of doing the smile. Now we have a new technology that, you've been pretty instrumental in terms of bringing to Canada. It's called Smile. So did you want to talk a little bit about Smile?
Yeah. So again, we talked about how all these surgeries involve removing some tissue. So an excimer laser is like a vaporization laser. It just sort of zaps and the tissue gets evaporated and we have this vacuum. Sometimes people smell a little bit of burning because they're smelling the laser. And by the way, when they're having laser eye surgery, actually during the surgery, they don't feel a thing. Like, again, we just do it with drops. You don't feel a thing. But Smile, what we're doing is we're using the femto laser, which is a cutting laser, as opposed to a vaporizing laser, and we're creating what's called a lenticule, and we're this little wafer of tissue, and we make a small little incision instead of going almost 12 millimeters around the edge of the cornea, like this edge to create the flap. We're going through a 2 millimeter incision and just pulling this little wafer out. And so the result of that is the fact that it's kind of like getting the benefits of both PRK from not having a flap, because people can rub their eye. I mean, we didn't generally advise people not to rub their eyes, even if you haven't had surgery. But people can rub their eyes or get brushed or whatever. There's no risk of a flap movement. But then the flip side is they don't have this massive abrasion. They're less prone, not prone at all, but less prone to dry eyes and some of the other things like that we see with LASIK. And the outcomes are just as good. We'll say that, a good refractive surgeon has the same outcomes from a visual point of view of LASIK and Smile. If you're getting better outcomes with one versus the other, then maybe you need to improve your skills in the ones that's not so good. But I would say to you, when all else is equal and we have a patient who's a candidate for both, we prefer to do Smile.
Yes.
But Paul, the elephant in the room here on this one is you really trashed Smile when I first wanted to do it. You were like, Basir, this is dumb. Why on earth would I do this?
Yeah, you got me.
So I was like, yeah, I'm not going to listen to you. I'm going to just do it anyways. So I think it's your turn to sort of say, because now
to defend myself.
Yeah,
yes,
you're drinking the Kool-Aid now.
I am drinking the Kool-Aid.
So the pink Kool-Aid.
Yeah.
So why don't you tell us about like what changed for you?
Yeah, it was very interesting. I was a LASIK heavy surgeon, so I did a bunch of LASIK, and I have very good outcomes with my LASIK patients. I can get them done very quickly and very effectively. And Smile, when originally came along, Smile was only available for myopia, so only nearsighted patients, those patients that have minus prescriptions can get Smile. Hyperopic patients, like those plus 2.5 patients, cannot. It is technically more demanding than with LASIK. So with LASIK, all you have to do is create a flap. The machine does that. You just lift up, the LASIK flap, which is doable. You press a button, you're watching for certain things and you put in the flap back down. Smile requires you, as you were saying, you are creating a lenticule, or you're creating basically a little disc inside the cornea, and then you're entering a small entry wound to then dissect the top part of the disc inside the cornea, dissect the bottom part of the disc inside the cornea, and then pull that disc out to allow for flattening of that cornea, which then treats myopia. That's a little bit more technically demanding than LASIK.
Actually, I'd say it's a lot more technical.
A lot more technically demanding. So I was saying only for myopia, it's more technically demanding. And also, if let's say there is something called regression, let's say that patient that you did Smile on gets a small prescription back. You can't re-smile that patient. Well, you technically can't, but for all intents and purposes, we're going to do a LASIK enhancement on that patient. So on top of the Smile. So I said, why would I do all that? And there are very good arguments for all three. In terms of the first off, the Smile enhance with, why would I enhance with LASIK versus on a Smile patient? Well, let's talk about that LASIK patient that has to be enhanced. Now that LASIK patient that has to be enhanced, you're going to do a relift on that LASIK patient. So you're going to reuse their flaps. And so when you look at the risks involved, which is called something called epithelial ingrowth, microstriae, all these things, it's actually technically the risk probably a little worse for a patient that has to be secondarily enhanced from LASIK versus the SMILE than LASIK patient. So it actually is probably safer to have SMILE than LASIK than a LASIK enhancement.
And Paul, just as an aside, we've seen that the rates of enhancement
Are lower
for SMILE. They're not zero.
Not zero, but
they're,
much lower.
They're probably about, almost 50 to 75% less with SMILE than they are with LASIK, especially for patients with higher prescriptions.
Yes. The hyperopia argument. The hyperopia argument that I made, which was, for the far-sighted individual, well, we're leaving out a significant portion of the population that can't benefit from SMILE. Well, number one, SMILE can now do hyperopia in Europe and will basically also be coming to Canada and the States for that. So that's no longer going to be an issue. But secondarily, when you look at the number of patients that are hyperopic and young, you're talking about a very small proportion of patients that wouldn't have benefited from SMILE. So you're not talking about a large population there. So I think that was probably, a little overkill. And the last one, which is, well, it's more technically demanding. Okay, let's compare this to what we had just talked about in terms of cataract surgery. In cataract surgery, it was probably easier to do that large incision and pull that lens out really quickly, right? And then maybe even stick that big 6 millimeter lens in and do a little suture up than it was to learn phaco. Phaco was technically more demanding than the previous surgery called extra cap before it. But there was a benefit to that, and that came to the patient. That came to reducing the size of the incision and better outcomes for the patient. So if I have to do something that's technically more demanding, which is SMILE, but I no longer have to worry, and the patient no longer has to worry about having a flap and having potential traumatic issues post-op, malposition issues, wrinkles in the
Zero
flap.
issues.
If I have to do something more technically demanding to give that patient that benefit, why wouldn't I as a surgeon? And so, yeah, I drink the SMILE Kool-Aid. Yeah, you were patient with me. Yeah, I saw the light, and I'm a full SMILE convert now.
You know the one thing I hate about SMILE, Paul?
What's that?
The name.
Yeah, I agree.
Right? Because people hear SMILE, they think it's something like dentistry thing.
Yes.
Yes,
yeah,
right?
Yeah.
They had to come up with a better. Unfortunately, it's proprietary. It's like it's kind of everyone what it refers to it as SMILE, but it's a bit frustrating. The other thing too in Toronto, anyways, is that there's only a few centers. We're one of them that actually do SMILE.
Right.
There's a number of centers that don't. For whatever reason, some of them maybe they don't feel technically that they have the same number of surgeons that can sort of work at that skill level. Others that it's not cheap, right? These machines are pretty expensive, and they don't want to make the investment. It's been a bit frustrating for some of our colleagues who don't do this to sort of trash the technology. And to be very clear, we're not trashing LASIK.
No,
LASIK is a great procedure. We do a lot of LASIK.
We do a lot of LASIK, and LASIK definitely has benefits. And I'll tell you where I use LASIK. Mm-hmm. I use LASIK for those hyperopic patients for sure. Yeah, absolutely, because LASIK is unbeatable. Yeah. I also use LASIK for patients. Let's say they had cataract surgery and they had a small error, like a refractive error afterwards. LASIK all the way. There's nothing competing with. So LASIK definitely has its spot, and we do a lot of it. We're not trashing LASIK at all. We're saying, all things being considered, for that myopic patient, if you're choosing LASIK versus SMILE, they're equivocal, and we tend to kind of nudge people a little bit towards smile just because of the benefits that we talked
So
about.
Paul, you had LASIK, but that was like whatever, 14, 15 years ago.
Yes.
If you had to have surgery today, what would you have done?
Yeah, I would look towards smile. I'm a basketball player, so it's always a bit of a concern. If I don't play with goggles or anything like that, but it always is in the back of your mind. You don't have to have that concern if with smile, because if you get a scratch after smile, it's just a scratch. What we would say to patients who are getting laser vision correction, I'm sure you get this question a lot.
Okay.
How do you handle the patients that they have two questions for? One big question for you. Actually, we'll talk about two questions. Question number one, am I going to mess it up? So how do you answer that question?
We kind of talked about this before, right? The worst case scenario is, the first part of the laser, whether we're doing smile, well, there's only one laser in smile. And then in LASIK, it's the part about doing the flap. We're using a femto for both. There's a point where patients on the bed and we move them closer to the laser sort of suctions onto their eye. It's like a vacuum. It holds their eye relatively still. Now, if somebody forcibly moves their eye, then they can break that suction. But the laser is designed so that, as a safety feature, that it automatically stops. 90% of the time, there's no issues with what we call suction loss or patients forcibly moving their eye. There's a fixation light. Like the laser that we use, unlike some of the other lasers that are out there, like we use what we believe is the best laser on the market for this, for cutting. Other lasers cause like this blackout effect. Ours doesn't. And you have a fixation light the whole time. And as long as people just look at that light, they're okay. And 95% of the time they're able to, and we get through it no problem. And they don't feel a thing. I tell patients, just look at the light. You're not going to feel a thing. Just keep breathing. Keep your hands inside the ride at all times. I'll talk you through it. I don't want you to talk back to me, because when you talk, your head moves, and I want your head to be still. And most people are fine. If for whatever reason they do move, the vast majority of those times, 90% of the time that they move, if they do move, which is less than 5%, we can just redock, restart, and we're good. On the off chance, and maybe 1 in 1,000 cases, for whatever reason, we don't feel that we can proceed, we just stop. And as you said before, worst case scenario is they walk out the way they came in. We just sort of leave the eye for a week or two. We can come back. Maybe if we were trying to do smile, we can do LASIK. If it was LASIK and there's issues, maybe we try again, or we do PRK. There's always things that we can do. That's the first part. The second part, if we end up doing LASIK, the examer has a tracker, and the tracker automatically turns off as soon as the eye's out of the sweet spot or hot zone. And so again, it's really the volume of surgeries that have been done over the last 20, 30 years is so massive. Companies have poured in a significant amount of money to developing really robust, reliable, and safe lasers.
I would agree. I mean, the talking points that I tell prospective patients is there is nothing you can do to mess this laser up. Nothing, because that's a big question or concern that patients often had. Am I going to mess it up by looking in a different direction or looking the wrong way? So to address the pain issue, I say every drop that you get during the procedure is a numbing drop. You're going to feel no pain. You might feel a little bit of pressure at some point. I'll tell you about the pressure. The pressure likely won't take away what you're seeing, but you might feel it and you're going to expect it. That's normal. In terms of what are you going to look at? Just to your point, I would say that there is a tracking device. So there is a blinking light. Your job is to stare at the blinking light at all times, almost be like a zombie and stare right through it. And that's all you have to do. And let's say you're staring at that light, that blinking light, and something happens, and you look away for a second. No problem. Number one, I'm looking at you. I'm watching you. I'm making sure you're in the correct position, and my foot is on the pedal. And if I get a sense that something's happening, my foot's off the pedal. Number two, even faster than my foot and my eyes is the laser tracker. So the laser tracker is faster than that patient's eye movement. So if that patient moves out of the tracking zone, laser shuts down. So patients often, when they hear that kind of allays their fears in terms of, I can screw this up. patients can't screw up anything as long as they look right where they're told. It's usually a no-brainer. And to what we talked about, the worst thing that's going to happen is you're going to walk out wearing the same glasses you walked in with. I think laser vision correction is safe, and it's been a freeing technology for lots of people who have the disability of having to wear glasses a significant period of time.
I think it's worth noting just because it's really the one serious complication that can happen after laser eye surgery is something called keratoconus. And so
Ectasia,
Sorry?
Ectasia. Yeah.
So the way to think about it is think of a wall. If you start to thin a wall out, sooner or later, if you make it too thin, it's not going to have the support. And so if you make the cornea too thin, it can start to get a little wobbly and warped and starts to get distorted. We do this is not just us, everybody. We put, again, people through a battery of tests. If there's any concern that we have about somebody's cornea being too thin, we just don't do surgery. And although it's not absolute, there's certainly some suggestion that SMILE may actually be a little less likely to develop ectasia than LASIK, but that's still yet to be borne out. But there's certainly some suggestion that that's the case. But I think it's just, when we talk about complications, we should always think about what's common and what's serious. But ectasia is exceedingly rare. And again, we're really good at picking up anybody who's potentially at risk.
Awesome. Let's move on to something that you asked me about before, and that's something our 45-year-olds and older patients often come into our clinics about, and it's like, I have a brain tumor, I can't read anymore, I could read yesterday, I can't read today.
Or the emergency room.
Or the emergency room. We get it all the time.
10 o'clock at night, some guy walks in, I can't read anymore.
Yes. And it has a technical term. It's called presbyopia. So these are patients usually, 44 to 50 years old. They had full range of vision. They could read. And then all of a sudden, the lens in the eye that we had talked about, we take off for cataract surgery. In these patients, obviously, the lens is still in the eye, but it's lost its ability to focus. It can change shape in our eyes when we're 20 years old. It gets fatter, it gets thinner, it gives that focus. In your mid 40s, it loses that elasticity and it cannot no longer focus for close. Patients lose their reading vision, very upset, and often are looking for options to bring back their reading vision. So that's called presbyopia. In your repertoire of technologies, what do you have in your back pocket for that 50-year-old patient that's looking to regain reading vision?
So the two things that we've been doing, the first thing that we started doing, I think, was actually the framework for what we've done everything since then, is a procedure called Presbyond. And I think we're the only guys really in Canada that talk about it or do it. And again, this is one of those things where we, as an organization, have invested a lot of time and effort in trying to understand this technology and training the staff. For all intents and purposes, it's LASIK as a procedure, but the ablation or the treatment pattern is a little bit different. And we're creating a spherical aberration, which again, won't get too technical into that.
Right.
But what it does is it creates a depth of focus and sort of stretches out light coming into the eye to give a longer range of focus than a conventional lens or cornea or ablation would. So what we do is we make one eye slightly better for distance and one eye slightly better for near, but 75% of the range of vision for both eyes is overlapping. And so we get good binocular vision or stereo vision, but we get good distance and we get good near. And the brain works very well at sort of fusing these images because our brain is a very powerful device that's able to sort of overlay these two images. And it's understanding that principle that sort of has extended us to, even when it comes to lenses and intraocular lenses, when we talked about cataract surgery, is mimicking that outcome with any number of lenses. So I would say, so we have basically when somebody comes in and they're 55, they don't have a cataract, but they're like, listen, I have trouble reading. Like, what can we do? If they're myope, so if they already have glasses where they can take them off and read, but they can't see in the distance and they're having bifocals, they're a perfect candidate for Presbyond. So we're going to treat both their distance and their near at the same time. I would say to you, like, I can't think of a Presbyond patient that we've done since the beginning. Honestly, that's not happy. Like, I really like I hate saying that because it sounds disingenuous when you say every patient, because there's got to be one. I can't actually think of a single patient that we've done Presbyond on that wasn't happy, that was myope. The hyperopes, we were a lot less, and it's for technical reasons. Hyperopes or people who are plus, have plus prescriptions, are a bit harder to treat with LASIK. Some of them took a little longer to adjust, and we were more sort of recalcitrant to treating them for a whole bunch of different reasons. Now, for those +1 hyperopes, or the people who are just a little bit hyperopes, the adjustable lens has given us the precision where we can treat these people in a way that we couldn't before. Because they were too good to use other lenses because we couldn't be precise for intraocular lenses, so early cataract surgery, if you will. And we didn't have the greatest outcomes with laser and hyperopes. So, when a 55-year-old with a slight hyperopic prescription before would come in, I'd be like, what, just wait till you're a little worse and come see me in a few years, right? Because at the end of the day, I want them to leave better than they came in. Otherwise, they're not going to be happy, and then I'm not going to be happy. But now with the light adjustable lens, we have that precision where we can do that really well. But the resultant outcome is relatively the same, whether it's Presbyond or the LAL, which is we're sort of targeting one eye slightly better for distance, one eye slightly better for near, and using that spherical aberration to create the depth of focus. And one of the things I just say, so dominance, most people have a dominant eye. And so what we do tell people to do, even it's helpful when they come in and tell us which eye's dominant, is, sometimes you make a little hole through your hand here, just like this, and then you ask them to pull it back, and you see which eye they're looking through, and whichever eye they're looking through is their dominant eye. Right. Because sometimes not everybody knows. Right. But yeah, and so what we do is we target their dominant eye for distance and their non-dominant eye for near, and they do really well.
Yeah, I would have to say, I get this a lot now because, my cohort is, mid-40s, early 50s. So there is a misconception out there about LASIK. Oh, I thought LASIK could only treat your distance vision. Presbyond LASIK, which we offer, can treat both. So it treats both distance vision correction as well as reading vision correction. And
but Paul, we're the only ones doing it.
We're the only ones doing it, yeah. So, I often have to tell my friends, no, it's true. There is something out there. Well, but I heard otherwise. No, it does happen. But it's this very specialized laser.
No, we didn't invent this.
We did not. No.
It's not something that we did.
No, Zeiss is the brand name. It's obviously a very well-known laser company, and so this is their proprietary laser design. But it works remarkably well.
And we went to London.
Yes, we did. Yeah.
To learn from the Godfather,
Dr. Dan Reinstein.
Dr. Reinstein at the London Vision Clinic.
Yeah.
Who did all the seminal research on this.
Yes.
I mean, the man's a genius.
Yes.
And we went and we studied with him, both you, me, our entire team.
Right.
Who's part of this, because the surgery is actually kind of the easy part.
Yes.
It's the workup.
It's the I really think it's the pre-op
100%.
evaluation.
Yeah.
And Dr. Hassan Qureshi is one of our other optometrists. He is meticulous.
Yeah. He's OCD. Obsessive.
In that workup.
Yeah.
And I think that is probably the secret sauce.
100%.
To giving us the outcomes that we have. Yeah. And in terms
shout out to Hassan.
Shout out to Hassan. And when I agree with you, like in terms of what we had for presbyopia correction before the light adjustable lens, it was LASIK, right? You would do LASIK for the myopic patients. You do LASIK for the hyperopic patients up to a point.
Yes.
And then +3. And then you would move over to something called an RLE, which is called a refractive lens exchange, which is basically cataract surgery. Except
it is cataract surgery, except you don't have
patients don't have a cataract.
Yeah.
They have a clear lens.
Yeah.
You're taking it out. You're putting in one of these fancy lenses to try to give them range of vision. For those patients that did not have much of a prescription for distance, meaning they were seeing 20/20 at distance already.
They just wanted their
They
reading.
just couldn't get their reading.
Yeah.
Those were problem patients
Yes.
before because, again, of that about hitting that hole in one. They're already a hole in one.
Yeah.
And now you're trying to take out their lens and replicate that hole in one. Very challenging with other lens technology because you're getting close to the hole, not at the hole most of the time. Now with a light adjustable lens, sure, we're gonna get the putter out. We're gonna get them back their perfect distance vision, and we're gonna give them back their reading vision. So I think those are the two things that we have in our back pocket for presbyopia correction: Presbyond and the light adjustable lens. Finally, we're kind of at the end, nearing the end here, and we're gonna talk about something really fun. We're going to talk about some new technologies. We'll just spend a couple of minutes on this. This is pretty cool. We're not gonna spill the beans too much. But did you want to talk about some things that are down the pipeline, maybe a year or two, maybe even one of them a year or two down the line, and one maybe a little longer down the road?
Yeah. So I mean, we're sort of involved with a couple of companies that are doing some really neat things, and I think we've prided ourselves, Paul, at always trying to stay ahead of the curve. We've had a lot of firsts. We've talked about today where they're first in laser cataract surgery, even though we kind of jumped off that bandwagon. First with the adjustable lenses, first with a whole bunch of other lenses that have been come to market. And we'll unless something drastically changes, we're going to be first to some of these other technologies. One of them is a device that actually changes eye color. So right now, if you want, and it's purely cosmetic, so it's not therapeutic. Right now, if you want to have different colored eyes, there are three options available in the world. Colored contact lenses, which, I mean, you get within a meter of somebody, you can tell they're wearing colored contacts. And plus the iris doesn't move, it's fixed, right? Now, obviously those are approved in Canada. Number two is iris implant. So it's a silicone implant that goes inside the eye. Now, they're not approved anywhere in North America, and there's good reason for this. I've had a couple of patients who have had them done overseas, and their eyes are an absolute disaster. One poor young lady went down somewhere in Central America. Her eyes are she's legally blind. She's had multiple corneal transplants, glaucoma, cataracts, the whole bit, because the material in that reacted very poorly inside of her eye. And she's not unique. Like, this is well known, which is why it's never been approved in Canada or North America. The third thing, and they're doing this in New York, and it boggles my mind. So it's called keratopigmentation. What they're doing is they kind of hack the smile laser that we're doing. They're creating this pocket, and they're putting
Pocket in the cornea.
Pocket in the cornea.
Yeah, in the cornea. Yeah.
They're creating a pocket in the cornea, and they're putting this metallic stain or tattoo material inside the cornea. And
so almost like a tattoo.
Yeah, it's a tattoo.
Yeah,
it is a tattoo, and you can put different colors in. But here's the problem. You can't get this stuff out of your eye. So I had a friend who had this done, and I begged this person not to do it, and they still went and did it, and decided afterwards that, you know what, because it changed color too. It was initially brown, then it turned to orange because of some oxidative stress, and then tried to have it removed. She can't get it all out. It's stuck in there. And here's a problem. If you can't have an MRI because there's metal in there. And if you go and have an MRI, it oxidizes this stuff, and it's going to create massive problems for the eye. These guys don't know how. They had a conference last year, and they're still talking about they don't know how to get it out, and yet they're actively promoting this stuff. Like it boggles my mind that the FDA hasn't shut this down in some way. Of all places in the U.S.,
right.
That's so litigious. So, all that being said, what this technology is going to do is think of it as. How does a tattoo removal laser work? What it does is if you got a tattoo, you apply a laser, it activates, certain cells that are responsible for breaking pigment down, and then breaks it up slowly, and then it kind of fades. All of us have blue eyes. I mean, Paul, your eyes are beautiful, but even though they look brown.
So, yes.
But all of us have blue or gray eyes.
Yeah.
It's the pigment that's there. right? So what you do is
we all have pretty much a similar color at the base of our colored part of our eye, but some of us have more pigment, whether it's the skin or in the colored part of our eye to give us darker colored eyes. It's the pigment that gives us a darker appearance.
So it's the idea that basically what we're doing is we're going to be able to apply a laser to just gently get the eye to decolor, so to get a bit lighter. So
we're targeting the pigmented cells of the colored part of our eye.
Correct.
Yeah.
So so it's only going to make your eye lighter. It can't make it darker because it's not adding anything to your eye. It's just subtracting a little bit of pigment from your eye. And you can titrate this. So, you could go from dark brown to medium brown to light brown and maybe even green and then blue-gray if you really wanted to. Although, that would look kind of weird for us.
Too rock star.
There you go. But yeah, so we're expecting this is going to be maybe a couple of years out.
Right.
I
think the important thing to it is the preliminary safety data is remarkable.
Yeah, but yeah. So I mean, when and if approved, hopefully, it's going to be really safe, right? So all those other issues that we're talking about go away, right? So are you going to do it?
I will be honest with you. If we get our hands on this thing, yes, shade lighter. Who wouldn't? I got to tell you. I got to tell you.
Yeah.
We're refractive cataract surgery. We're refractive surgeons, right?
Yeah.
So, inevitably, you go to a party or something, people start talking, and it's interesting to talk about, laser vision correction. When I tell people that there is a potential laser coming down the pipeline that can lighten your eye color safely, the level of excitement and interest is through the roof. So it is something that I think will have a lot of traction. It's going to have a lot of excitement. People are interested. Yeah, I'll probably get it done.
I wonder if we should just get like one eye done. So this is what it was before, and this was after.
Yeah, there you go. Before and after, all at the same time. Yeah.
The other technology that's going to be interesting, and this is like really like next level, like cyber.
Not anytime soon.
Not anytime soon.
Not anytime soon.
But this is going to be like like almost like Matrix kind of stuff. Yeah. It is going to be potentially a lens or something we can implant inside the eye that has a camera and a projector on it. So, imagine, like you have like Google glasses or Apple. I don't think Apple has glasses. Google has glasses. Meta has glasses. Yeah. And instead of having glasses projecting, imagine like you've got something inside your eye that's actually projecting. So like we could be having a conversation here and I'm having all this information scroll through my vision that you can't even see.
Right.
Or like I walk into
augmented reality.
Augmented reality. Or I walk into a presentation or I see somebody and facial recognition, Paul has 2 kids, a wife and a dog. I'm like, hey, how's the dog doing? No, it's this type of dog. Like it's
or a Google Map that'll lead you. Yeah. That'll lead you. Yeah.
Yeah. Or you play Pokemon and or Pokemon Go and no one knows.
Insane.
Right. So there's some really interesting things that are coming down the pipeline. I mean, I think we're right at that front, and we're always looking to bring new things to our patients. We're never going to compromise safety. That again, the best example of that is we jumped on and off the bandwagon with laser cataract surgery, but we're always looking at new things and trying to keep us and our team innovating up to date.
Yeah, innovate and disrupt, my friend. Yeah. All right, well, it looks like we've run out of time. So we want to thank everyone for watching the inaugural Lumea I Know podcast, where we did a deep dive into vision correction, and hope we've been able to summarize some of the most common questions that prospective patients may have before considering surgery. I'm Dr. Paul Sanghera. I was joined by my partner in crime, Dr. Basir Khan, today. Please check out www.lumea.io if we've piqued your interest. Let's see if some of our Lumea surgeons can help you get out of your glasses and see things differently. Take care, everybody.